This is the cardiovascular examination video, lines 58 through 75 on your checklist.
Hi, my name is Deidre. I'll be your nurse practitioner today. Is it okay to listen to your heart?
Yes.
Thank you.
As always, you start with an introduction and hand washing. Next, and firstly, you're going to inspect for jugular venous pulsations. To perform this exam, you elevate the bed to about 30 degrees so that the jugular venous dissection is mid-neck. Have the patient slightly tilt their head to the left and examine the patient from the right side.
Okay, so as you can see, I've got the bed at a 30-degree angle. And it's very important that you remember to do this in your final checkoff because it's a common mistake that students make in their checkoff. A lot of times they'll go from doing their abdominal assessment and move their way up the head and forget to elevate the head. The other thing you'll notice, typically if I'm examining a patient, I always approach the patient from the patient's right. That's because I'm systematic in my approach. I do the same thing every time in an effort to forget steps in my exam. So as I proceed with JVD, I'm going to have the patient slightly tilt his head to the left, explain to him that I'm looking for pulsations in the neck, just a slight tilt please, and then I'm going to identify the sternocleidomastoid muscle, look posterior to that, and look for pulsations, and I am going to verbalize that I can see those pulsations.
So, to reiterate, you examine from the patient's right side, head slightly tilted to the left, patient elevated to 30 degrees, and you're going to verbalize to the patient that you're checking for venous pulsations. A common variant of this is to begin at 45 degrees of an angle on the bed. The initial examination angle is less important than using correct technique and actually identifying the jugular venous pulsations. Different patients will require different angles for examination based on height, body habitus, and the presence of heart disease. Proceeding from jugular venous pulsations, we will now palpate the cardiac apical impulse, which is also called the PMI, or point of maximal impulse. You need to find the apical area and palpate the apical area, which is about the fifth intercostal space on the mid-clavicular line on the left. To palpate the cardiac apical impulse, you'll use the pads of your fingers. Moving on from the cardiac apical impulse, you'll start to auscultate Begin auscultation with the diaphragm of your stethoscope. Important and a common mistake is not to listen over the clothes or over an examination or hospital gown. Make sure to obtain adequate exposure of the chest wall and auscultate the correct areas for each cardiac valve. This may cause you to have to change the draping for the patient, but with your SP, a sports bra is considered skin in that instance. Start by auscultating the aortic area. That is on the right in the second intercostal space on the right sternal border. Then you'll auscultate the pulmonic area, which is on the left in the second intercostal space on the left sternal border. Then the tricuspid area, which is at the left lower sternal border at the fifth intercostal space. Then, moving slightly to your left, auscultate the mitral area, which is at the fifth intercostal space at the mid-clavicular line. Then you're going to switch to the bell of your stethoscope and listen again at the tricuspid area with the bell, then the mitral area again with the bell. The mnemonic device to remember this order is a person touched me again, which is aortic, pulmonic, tricuspid, mitral, tricuspid, mitral. Next, you'll start to palpate the pulses. You'll start with the radial pulses. You'll palpate each radial pulse individually, each side separately. Then you'll examine both sides simultaneously. This is important because a blood pressure drop from the left to the right may indicate serious illness such as an aortic dissection. Palpating a significant pulse pressure difference from left to right may warrant an actual blood pressure differential check. Make sure to adequately palpate all the pulses, just don't palpate the general areas. From the radial pulses, we'll move to the ulnar pulses. Again, you examine both sides. Next, palpate the brachial pulses. You'll palpate medial to the biceps tendon or biceps groove, and again, palpate and examine both sides. Moving further down the body, you'll palpate the femoral pulses.
I'm going to lift your short up to feel the pulse in your leg. Is that okay?
Yes.
Thank you.
Make sure to obtain adequate exposure to palpate the femoral pulse. A little different from the numbering on your checklist, examine for inguinal lymph nodes while the patient is positioned and you're checking for femoral pulses. Again, palpate both sides for femoral pulse and inguinal lymph nodes. Moving further down, we'll palpate the popliteal pulses.
I'm going to bend your knee up just a little bit. And an exam technique to help to find the popliteal is take your two thumbs together, push the patella back, put your fingers and get a little squeeze, and you'll go straight to the popliteal pulse. It compresses the pulse up against the patella. Do both sides.
Next, you'll move to the posterior tibial pulses. And then the dorsalis pedis pulses. Now, you're going to inspect the lower extremities for cyanosis or other vascular changes. Again, paying close attention to both lower extremities. Here, very importantly, you will verbalize and indicate to the SP that you're inspecting both lower extremities for cyanosis and other vascular changes.
I'm expecting your lower legs for cyanosis and other vascular changes.
Lastly, on the cardiovascular examination, you're going to examine for leg edema. Examining both lower extremities, you'll test over the distal tibia and dorsal surface of the foot, applying sufficient pressure to elicit edema if it's present. This concludes the cardiovascular examination.